Adesso presenteremo la dottoressa Consuelo Mancias Guerra. È un membro del Dipartimento di Hematologia presso l'ospedale universitario Dr. José González di Monterrey, Messico. Qui ha fondato il laboratorio di crioconservazione e la prima banca del sangue cordonale pubblica. La dottoressa Mancias Guerra partecipa attivamente alla formazione dei medici residenti e degli studenti di dottorato. Ha scritto più di 20 pubblicazioni in riviste mediche e 8 capitoli in libri sulla pediatria ed ematologia. Ha vinto diversi premi nazionali di medicina e la sua principale area di interesse della ricerca è la terapia cellulare, in cui ha sperimentazioni cliniche in esecuzioni. Oggi ci descriverà quali sono le possibili terapie con le cellule staminali per i bambini affetti da paralisi cerebrali nei paesi in via di sviluppo.
First of all, I want to show you an icon of my city. This is named Horse Chair Mountain, and it's like an icon of our city. And I don't want to get deep in this theme because I know that a lot of doctors, Dr. Torrento, Dr. Sun, has shown you a lot of things in potential on stem cells. So what I just want to remind you, is that stem cells can be taken from adult or fetal or still embryonic cells. But my interest is especially on hematopoietic stem cells because it's where we worked. My background is hematologist and pediatrics, so as you may think, I like hematopoietic stem cells. So we know now that these hematopoietic stem cells doesn't work only for hematologic disease. So what we are trying to do is that we know now that these stem cells can respond to different cytokines. These cells are strongly attracted by ischemic or injury tissue extracts, and their migration is correlated to secretion of growth hormone in injured tissue, including cerebral tissue. A very good and special things about stem cells is that they have the capability of endogenous cell homing. What I try to mean is that stem cells can respond to different cytokines. These cells are strongly attracted by ischemic or injured tissue. Their migration is correlated to secretion, and this is costly and less costly and complex than approaches to require ex vivo cell manipulation. Maybe they serve as integrated participants in the target tissue to treat the root cause of this damage, or maybe they are the platform to deliver molecular signals to a target tissue without integrating to the tissue, or maybe both. We really don't know. This is just a very large list of different cytokines that are produced not just in the bone marrow, but in the cord blood tissue of the stem cells, that they are kind of more or less the same value in both tissues. And maybe some of them can act in that cell homing. Again, some of the doctors, Dr. Torrento, Dr. Sun, talk that they can regenerate, or there are research in regeneration of multiple tissues ongoing, like blood, bone, cartilage, cardiac muscle, skeletal muscle, skin, liver, lung, a lot of tissue, including nervous tissue. There are a lot of researching in different areas of stem cells and different tissues. Especially we're working in amyotrophic lateral sclerosis, osteoarthritis, and diabetes mellitus. And obviously in cerebral palsy. This stem cell research starts long time ago, for example, in stroke models and animal stroke models with intravenous human bone marrow derived cells infusion. Gordon write about 39 patients with Parkinson's disease, meta-reported safety of intrathecal application of marrow-derived cells. There are phase 1 and phase 2 trials in China and United Kingdom in patients with acute spinal trauma. As a doctor before told, there are more than 4,000 studies found in clinicaltrials.gov doing stem cell therapy. And these are just a little few of these trials about spinal cord injury, amyotrophic lateral sclerosis, autologous transplantation in Duchenne muscle patients, chronically injured human spinal cord. There are a lot of them. Especially, as I told you, we are working in knee osteoarthritis and autism. These are two of our major trials, including diabetes mellitus type 1. What we are doing here is that we are treating patients with a recent diagnosis that we call honeymoon diagnosis. And we are making autologous hematopoietic stem cells transplantation. And right now is a phase 2 trial for efficacy evaluation. Our primary preliminary results here is that patients, some of the patients are without insulin requirement. Now is still a short follow-up. We don't know if it's temporal effect. Few adverse effects and complication, and it seems that it's an economic advantage versus prolonged insulin use. Now, going deep in the stem cell biology in central nervous systems, it seems that stem cells can help neuronal repair through anti-inflammatory, immunologic, and trophic mechanism in addition to inducing angiogenesis and neurogenesis. It seems that angiogenesis is one of the most valuable fields of the stem cells here. They are capable of differentiating into in vitro and in vivo into astrocytes, microglia, macroglia, and neurons, produce neurotrophic factors, which in fact they help a lot, promote the limitation of the glial scarring, replace known neural structures, and mediate the inflammatory response. We think that this last issue can help more in patients with acute injury. In another trial, they treat patients with chronic stroke with autologous CD34 plus cells. There were 30 patients with cerebral infarction 6 months to 5 years after diagnosis. They inject this amount of peripheral cells, 3 to 8 million of peripheral blood cells. They make an intracranial injection directly to the damaged cortical tract. We think that they make a craniotomy. They have an insignificant improvement in this scale, which is an NIH scale, and another 2 more scales, which was different versus control group. Improvement in a cerebral metabolism was measured by PET scan, and there was a reappearance of electrophysiological response to evoke motor potential. They increased 6-fold the number of cortical spinal fibers. One doctor of our university hospital is involved in a trial about amyotrophic lateral sclerosis with preliminary results in 15 patients, which has more than 6 months or less than 3 years of the diagnosis with a follow-up of 1 year. They evaluate the special scale for this ALS disease plus the neurological assessment. The median age of this disease was 50 years of age. And the preliminary findings was a discrete improvement in gross motor function, reduction in dyspnea and orthopnea, and favorable results may correlate to the baseline status, which means that patients younger have more results than patients that were not so young. And talking about cerebral palsy, well, Dr. Sun talked a lot about this, brain migration and how they demonstrate this with umbilical cord stem cells in transplant patients of metabolic disease. She explained very well their trial, so it's not necessary for me to tell again about it. And we are conducting our own trial, which is doing in our university hospital. And we include 18 patients. There was a phase 1 study with intrathecal administrations of adult total nucleated cells. It was just about safetiness and preliminary efficacy evaluations of a 6-month follow-up. Before doing this in clinical trial, we need to go to our own ethics committee. We are a hematologic and autologous and allogeneic transplant clinic, which basically handle patients with malignant and not malignant hematologic diseases. We have a hard ethics committee that we keep in our back because of these stem cells trials. And we have a blood bank and hematopoietic stem cells use permission by COFEPRIS, which is the FDI-like commission, which is regulating us. And there's a big fight between two regulatory commissions, since we are cells derivated from blood, but we are transplanting stem cells. There is a fight between the commission who regulates blood banks and the one that regulates transplants. So, in the meantime, which the regulatory system which is regulating us is the one that has to be with cord blood banks. Our trial consists of 4 basic steps. The first one was stimulate the patient with 10 microgram per kilo for 4 days of colony stimulating growth factor, which is the one in charge of multiplicate the cells in the bone marrow. Here is an important thing that you need to know. Mobilization, which is the name that we usually use for this in transplant clinics, is to try to get out of the bone marrow the stem cells so they can be collected in peripheral blood. Our main issue here is not for mobilize the cells out of the bone marrow, but for multiplicate cells inside the bone marrow. So in this case, we can collect a more number of them in the bone marrow. So our intent is not to try to take them off the bone marrow, but multiplicate them in the bone marrow, because we are gonna collect bone marrow, okay? Of course, before starting this, we need the informed consent, and the parents can know all the possible questions that they can have, so they know very good what they are trying to do with their child. Okay, so The second thing that we have to do is the cell collection by itself. This means that we are going to make a bone marrow aspirate, which is 8 milliliters per kilo of the patient and no more, never than 150 cc's of bone marrow. This is what we do, the bone marrow collection, which is then put it in these tubes. And these tubes then after that goes to the laboratory to be processed. In the laboratory, what we do is that we separate the Buffy code, we make the CD34 plus cell quantification, and after that, doing that in the same day, the patient goes again to the OR, and just with sedation, we re-inject the cells through lumbar puncture. A big thing for us is that we don't use Clinimax. Clinimax is the machine that we use to separate specifically CD34 cells or CD133 cells. This machine uses a very specialized kit that we have to throw away every time that we use it. And at least in Mexico, this special kit costs around $8,000 to $12,000, okay? So we need to avoid that because of costs. So we don't do this. And as I told you, the fourth step is the intrathecal administration after no more than 4 hours of the collection, 10 cc of total nucleated cells, which means total nucleated cells. This means that we are re-injecting all the cells that have nucleus in the bone marrow, which this means that we re-inject mesenchymal, stem cells, and all of the white blood cells that can be there, okay? What to evaluate before and after the procedure? We evaluate the Battelle inventory, which is a scale that we use. It measures 5 different areas, which is personal, social, adaptive, motor, communication, and cognitive. These all are in the Battelle inventory. We obtain a total score, an intellectual coefficient, and the mental age in months. Just to show you some of the results, there are here 10 different patients, which their initial global score. What it is most important is this column and this other column. At the very beginning, these patients, for example, this one have a mental age of 1 month. And after the first month, a mental age of 3 months. Not all the patients have a good result, because if we want to see this one, patient number 7, it has a mental age of 5 months, and at 1 month, he keeps the 5-month mental age. But we can see really good results at the patient 5, which at the very beginning has 62 mental age month, and at the 1 month follow-up, 74 mental age. This is in just 1 month evaluation. Again, if we measure in each of the different issues of the Battelle score, we can see in all of them that the p-value was significant, and then that at the very beginning, for example, in personal social, they have 25 months of age in the media. In the first month evaluation, 32 months, and in the 6-month evaluation, 36 months. And so on in the different other 4 things that we evaluate in the Battelle inventory. If we graphic that in different patients, again, just the initial evaluation and the 1-month evaluation, this is what we can see. You know, an augmentation in the bars. The red bar is the 1-month evaluation. Okay, talking about our results, we can say that that is a simple and safe procedure that have some acute adverse effects with a minor without additional complication. And in 18 patients, what we seen was headache in 2 patients, vomiting in 2 other patients, fever in just 1 patient, and meningism in 1 patient. What we are thinking about this is, since we inject total nucleated cells, the neutrophils that we inject are releasing their granules that they have inside, and these granules by themselves can produce fever because they travel to the central region where fever is produced in the central nervous system, and in this way they produce fever. The big difference with the fever produced by neutrophils and the fever produced by bacteria or virus is that the fevers produced by neutrophils appears in the first 6 hours after the procedure, and it disappears by itself without any other maneuver than giving antipyretic medication without no antibiotic. The fever produced by any microorganism appears after 48 hours after the procedure, because first these bacteria or virus needs to multiplicate before start causing damage, and this appears after that. If we discontinue the antipyretic medication or the anti-fever medication after 2 days, no fever appears again. Okay, and the vomit and the headache produced by the big amount of cells that we inject is caused maybe because of the big amount of cells that we inject, and because these cells by themselves, without any bacteria or virus, can produce an inflammation of the brain barrier. So they can produce this, and it disappears again by itself. We can say that maybe in the first 2 to 5 days, the child is again in a good mood and in a good shape to go again to make their normal activities with no other complication. A very important thing is that we can say that it's a discrete increase in the mean of every domain, which you already know. The response was maintained at 6 months. We don't have any change in the MRI. The first evaluation before start with the treatment is an MRI. The MRI before and after in these 18 patients was exactly the same. What we think is not a very accurate image diagnostic exam that can tell us in these few months that something happened. So we're thinking that the things, that positive things that are happening in these patients, it's very microscopic, so MRI cannot detect it. Again, this was a phase 1 trial, so we cannot say that it's very hard to evaluate just a little few patients We want to demonstrate their efficacy, their safetiness, not their efficacy. So this is just to try to go into the next step, which can be a phase 2 trial. Again, this is just to show you some of the patients, their gender, their months, the cause of their cerebral palsy, which of them has different types of motor paralysis, which shows their MRIs, and that just 4 of the 18 patients had any of these side effects. We do think that these 2 patients had lingual edema and laryngeal stridor because of the anesthesia and not because of the stem cells that were injected. So improvement was observed in the first month after the procedure. And this improvement was not correlated with patient age or any other variable, which allow us to suspect some grade of total nucleated cell action in the cerebral spinal fluid. This means that we had patients with just 1 million of cells, of stem cells injected that have a lot of improvement. We have patients with 20 million of stem cells with less improvement. We have patients with 8 years old that have more improvement than one that has just 2 years of age. So we cannot correlate any of these variables. The reason why we do not inject a very specific amount of cells is because every of us, if we are injected with colony stimulating factor, growth factor, will produce different amount of cells. So since we are working with their own bone marrow, we cannot predict what amount of stem cells is going to produce each patient. So we try to inject all the bone marrow that we harvested that same day. Obviously, we think that the first month evaluation can be very correlated with the cytokine production, not with the transdifferentiation of these stem cells that are gonna maybe produce then neurons or glia or whatever. This is just a graphic to tell you the media of improvement in the patients. This was they were before the treatment, these at 1 month, and these at 6 months. As you may see, they keep the advance they have, and they do not go back again. And this other one was divided in each of the domains that Battelle inventory evaluate. And all of them have different amount of or degree of development. Okay, our study conclusions are: there are no determined factors, as I told you, gender, age, type of paralysis, amount of CD34 cells to be injected for the improvement of the patients. We need a phase 2 comparative group control study to try to prove not the safetiness but the efficacy of this treatment. There are a lot of questions to be answered still. In 2010, still Braxmeyer was asking by himself, can they be clinically used? Are all the stem cell populations really progenitor cells? What is the real stem cell range of differentiation? How far can they be regulated? We need, obviously, a greater understanding of the functional, phenotypical, and proliferation potential of the stem cells, including which cytokines are helping with this. Obviously, we have a pessimistic side of these trials, which can be that regenerative medicine is still growing and can produce a great and anticipated expectations. This brings hope and enthusiasm for future applications, although at the time we are not sure if it could be a false hope. We can be carefully optimistic but realistic about the clinical use of this procedure, but without interfering with the science of clinical control trials. The optimistic side is that we are going to start the phase 2 randomized open-label control group trial just with quadriplegic cerebral palsy patients and just between 6 and 9 years old of age, which was recently approved by our ethics committee. There are other trials in different parts of the world that are working with cord blood cells, with bone marrow, with adipocytes, autologous or allogeneic cells. And the reason why we are including just quadriplegic patients is because of the chart that Dr. Sun showed you before, which says that in the first 5 to 6 years, the patient tend to go up, to develop a little bit more by themselves in the clinical, in the natural history of cerebral palsy. Then they stop on that improvement and they keep like that for the rest of the years. So since many neurologists are very skeptical, the one that we are working with, says the only way that I can believe you is to try to work with this very specific group of patients so we can know if it really works or not. Conclusions. Ethical use of stem cells is our priority. These cells have come to stay and will be used for medical research and treatment. And the human being can aspire to live better and maybe in longer time. And this one is just to let you know that I don't pretend to be Marilyn Monroe, but maybe stem cells can, okay? And this because she says that she was not perfect, but parts of her was. So maybe stem cells can be excellent too. And as Forrest Gump, we cannot run in these clinical trials. We need to go step by step to see if they really work or not. And as you may know, patient safetyness is and must always be our priority. This is the moon trying to sit in our horse chair mountain there at Monterey. But really, this is our most important issue in our patients. This is the facility where I work and our hospital. And this is some of the people that work with us, but especially I want to thank Dr. Alma Rosa Marroquin, which was the only neurologist that worked with us because all the rest of them says no. So we are as any other multidisciplinary team, but thanks to her, we can evaluate all the patients that we include in this study. Thank you very much.